Our first panel certainly set the bar quite high, but I am confident that our next distinguished group will meet that measure for measure. My name is Steve Chanenson. I'm a professor here at the Villanova University Charles Widger School of Law, and it is my pleasure to moderate panel number 2 entitled Responding to the Crisis Policy. And you can see from the program that we have 4 very distinguished speakers. I'll introduce them briefly and then get out of the way. We'll be following, I think, a fairly traditional format. We'll ask each of our speakers to talk for about 15 minutes, which will give us about 15 minutes for questions, both here and from our overflow room. So to my immediate left is Barry Denk, the director for the Center for Rural Pennsylvania, which, as you will hear, has been very active on this issue. To his left is the Honorable Joanna McClinton, member of the Pennsylvania House of Representatives, who has been one of the legislative leaders on this issue in the Commonwealth. Next to her is a homecoming of sorts. It is Dr. Jordan Hyatt, a graduate of this law school, and went on to get his PhD in criminology and now teaches at Drexel University, who is engaged in work with the Department of Corrections on treatment for folks who are afflicted with this addiction. And batting cleanup, we have the Secretary of Corrections for the Commonwealth of Pennsylvania, John Wetzel, who, as I said to him this morning, is in so many ways really the Secretary of Public Safety for the Commonwealth. And we are thrilled to have all 4 of you with us. With that, Mr. Denk, I turn the podium to you.
Thank you. Good morning, everyone, and thank you for coming. Very briefly, just about the Center for Rural Pennsylvania. Some may wonder why in a suburb of Philadelphia we've got a rural guy here, but the Center for Rural Pennsylvania is a legislative agency for the Pennsylvania House and Senate. We're to conduct research and collect and analyze data to look at issues and opportunities that are playing out across the Commonwealth, but particularly from a rural lens. Some may not know that Pennsylvania has the 3rd largest rural population in the nation. Number 3 behind Texas and North Carolina. We are maybe only 27% of the state's population, but rural Pennsylvania comprises 75% of the land area of this Commonwealth. And that really presents the challenges that we often see in rural Pennsylvania, is geographic isolation and lack of population density, particularly as it relates to public policy. In terms of the visibility of the issue or the challenge or the opportunity, and the ability to aggregate resources, whether it's in Harrisburg or whether it's up in Potter County, to really get the job done. And so our agency is to help educate and inform the body of the General Assembly about what's going on in rural Pennsylvania so that there is fair and equitable resource distribution. And that's what we're all about. A couple years ago, in 2014, we were partners in holding a rural health conference in Harrisburg for state legislators. And State Senator Judy Schwenk was there from Berks County. And as they went roundtable and talked about issues, she said she is seeing the issue of overdose and deaths in her district. And not in the city of Reading necessarily, but in outlying rural components of her district. In fact, over the past several months in 2014, they experienced 4 teenagers overdosing and dying from heroin. So afterwards, I went up to her and I said, Senator Schwenk, if you think there's something the Center for Rural Pennsylvania can do, please talk to my chairman, Senator Gene Yaw, who's from Williamsport. She did that very day on the floor, and that afternoon I got a phone call and he said, we will do something about this. And today I sit before you, and we have held 10 public hearings around the state. We have had over 160 professionals from all walks of life and disciplines talk to us about this epidemic that's affecting this Commonwealth. And we have over 50 hours of testimony submitted to us, all of which is available on Senator Yaw's website if anybody has 50 hours to sit and look at this issue. And clearly what we found was that this is not, as you know and have heard, this is not an inner city problem alone. This is not suburbia alone. This is not rural. It is the entire Commonwealth. How we address this epidemic and how we pull resources together from a rural perspective is why I think I was asked to come today and talk with you about things that we found out through those hearings. These are not observations from Barry Denk. These are observations that we heard from over 160 individuals across the Commonwealth and what could be done and what needs to be done. And so in fact, we are having another hearing next Tuesday in Indiana at IUP. Continue to have requests because there continues to be concern that there needs to be greater awareness about this. And some may question that as we sit here today. And I struggle with that. How many hearings can one hold on this issue before action takes place? But in fact, we are finding out there are still some myths out there about who are our substance abuse individuals, about treatment options, even in the law enforcement field with Narcan. We have police officers refusing to administer Narcan. There are police departments still in this Commonwealth who do not carry and administer Narcan. And some of that is based on myths of the cost factor. We can't afford it. If after the initial supply of naloxone is provided, how can we afford this? Training for our officers, how that's going to get done. And we even heard, and this was from a public survey that we did of over 1,000 police departments, and we got a 53% response rate, which is pretty good for survey research. The second reason why they didn't want to carry naloxone was fear for their own public safety. There are still concerns about the administering of naloxone, even though we all know it can be administered safely. But concerns about somebody coming out of an overdose and how they might react and how they might deal with it with the individuals around them. So there's still an awful lot of education that needs to be done. And so while legislation has been passed and has been in effect for a couple years, we still have a ways to go in terms of educating all walks of life about this epidemic and how it's affecting us and how we need to deal with it. Even with the prescription drug monitoring program that was unveiled just a couple weeks ago, the reality is in parts of rural Pennsylvania where we still have docs who have private practices, or we have docs that are in small practices. And so they will comply with the law, but the time it takes to get into that system and enter data or retrieve data so that we can prevent what we want is the ability for individuals to do doc shopping and get multiple scripts. That will present some challenges for our rural docs, where technology in their office isn't what it is sitting in this university right now. And that is the reality that we're seeing still in parts of rural Pennsylvania, with how this epidemic is looked at and considered and how we pull resources together to deal with it. In some of the hearings we held, one was up in Bradford, PA, McKean County. We heard single county authority, and they run the drug and alcohol programs. They have to refer to counties 30, 35 miles away for treatment. In Philadelphia, you're blessed with an abundance of providers. You still have waiting lists, and you still have people sitting in waiting rooms. But sometimes, just to visit somebody for an assessment, it's 35 miles away. And if that individual overdoses at 2 a.m. and the police officer or state police person is on the scene, how can you get them into the system that quickly? Those are some challenges that we're faced with. Some of what we heard from the hearings in terms of public policy and implications, and that's what I want to relate to you today, not my personal observations, but what we heard from some of those 160 professionals around the state in terms of law enforcement and the judicial system and the impact for them. And it was stated in the earlier panel, we cannot arrest ourselves out of this situation. But when you look at individuals who are suffering from a substance abuse disorder and they commit petty crimes to support that habit, it might be burglary or other types of things, level 1 and level 2 crimes. Because of limited funding, they cannot get referred into certain programs. You have to commit a level 3 and 4 crime before some funding is made available for them. So it's almost like we're waiting for them to do a much more serious crime before some state funds can be kicked in to support them. And that's the reality of limited funds. And I will say this up front. In terms of this epidemic, I don't believe anybody in Pennsylvania was ready for it. I don't believe law enforcement, the judicial system, the treatment providers, the education and prevention folks, and state government and the legislature. I don't think we were prepared for this epidemic and aware that it was going to hit us right between the eyes. And so some of us are playing catch up, and that's the reality. And when you look at the legislature and in terms of budgets and funding, everybody's juggling priorities. I think the legislature clearly understands and the governor clearly get that this is a public health crisis, and they're doing everything they can to address it in different ways. But the bottom line is there's just not the money out there right now. And so how do you prioritize, and how do you make sure that your investments pay off? We heard at some of the hearings concerns about fragmentation of services. How are things going to be coordinated? Well, I think part of the reality is for a lot of these agencies, these single county authorities, be they urban or rural, they've had to piecemeal partnerships and programs and collaborative efforts all along over the years, because they had to get money from somebody, they had to coordinate with some organization to provide some level of service. So in effect, they built a system of delivery that on the surface, from somebody who may not know, sees it as being fragmented. But in reality, they're doing the best job that they can. But after a while, that network becomes cracked and fractured, especially when the demand for services increases to the point that it has. When you look at those who are incarcerated, and the secretary can talk about this much better than I, so I'm just going to briefly get into that scene. You have the cost of incarceration, but you have also the cost of treatment. We had one prison county warden tell us that 80% of his inmates have a substance abuse disorder. And so he needs to coordinate services for them, but also the cost of incarceration. And so we look at drug courts as an alternate means to service those individuals who have entered the criminal justice system, but because they have an addiction problem and they've committed some type of crime. Currently in Pennsylvania, of our 67 counties, only 31 counties have some form of drug court. And so that is a policy issue. Is that something to be looked at and maybe mandated? But at what cost? And who incurs that cost and who pays that cost? But drug courts have proven to be an effective means. But they are limited in where they're at and where they're operating correctly, right now. In terms of treatment, extended stay. We've heard a number of concerns from parents and others about many insurance companies saying 30 days is what you're covered for. In fact, there's legislation on the book already, federal and state, about health parity insurance laws, that if you are covered under an insurance plan for a medical procedure and your doc or psychologist says you need extended stay for a drug addiction issue, your insurance coverage is to be there. But we still have heard stories where individuals, in effect, have to fight with insurance companies for coverage. And so we heard that over and over again. But there is legislation on the books that deals with that. But it's a matter of making people aware of what's going on. Dr. Levine talked about the detox beds, the lack thereof, and the lack of inpatient beds as well for treatment. That issue is exacerbated in rural Pennsylvania, where if there are beds, you are, in fact, traveling multiple miles to get there, but oftentimes the funding's not there. And the reality of some of those treatment facilities is they've got to operate financially and be solvent. Funding out of Medicaid and the reimbursement rate for individuals for treatment is less than private pay insurance. And so some of these facilities really do need to have a mix of private pay plus government pay. And so how they strike that balance and do that affects a number of people who are dependent on government funding to underwrite the cost of their care. Narcan, I mentioned that and the importance of that. There's laws on the books, but it's not being implemented by all police departments. And even going into a pharmacy with a script, a standing order, not all rural pharmacies carry it. And so you can't just walk in and get it with your script. Sometimes it takes a couple days to, in fact, get that naloxone issue. In terms of education and prevention, the drug take-back boxes and where they're at, how accessible are they? I'm sure for our elderly folks, if they're in a police department, they may not be all that willing to go to a police department and take them. But in rural Pennsylvania, that may be their only option is to get it there. And how far do they have to go to drop off those meds? It's the reality of some things that have to be looked at and considered. In terms of education and treatment, and Dr. Shapiro talked about this in terms of the medical society, but currently any of that continuing medical education is voluntary. There is legislation introduced that would mandate that part of your continuing medical education requirements would deal with opioid prescriptions and pain management. Not just continuing med for existing, but there is legislation that's out there that would require it to be built into curriculum for all the med schools across the Commonwealth. That latter issue is a little bit more controversial because, and understandably so, there's a reluctance from the medical community to have a legislator tell them what their curriculum needs to be. And so that balance of how do we arrive at that and achieve mutual goals, but in a way that doesn't hinder that process, it's a work in progress to see what happens. Roles and responsibilities of pharmaceutical companies, and as was mentioned, some other states have brought lawsuits against them. That's still pending. We'll see what happens with that. County coroners, and just getting the numbers. Because this epidemic really did hit us in effect over the head, even the reporting system, so that you have data available to analyze. County coroners are elected positions. They are not mandated to report, and their reporting is not equal across the board for all 67 counties. And when somebody dies, and heroin is a contributing factor, by the time some of that analysis is done, or particularly if it's a rural county and they have to send the blood away, it changes. And so the analysis may not in fact show that heroin was a predominant factor in that. And so that's the reality, that reporting is not consistent. And for us to get a handle on that is a challenge. Do you have legislation that requires that of county coroners when they are in fact elected officials? So many other things that we've heard from the hearings. Babies who are born to mothers who suffer from an addiction or disorder, and the cost incurred for that. And we also heard about mandating treatment for individuals who are revived with Narcan. And how do we deal with that? Because there are some folks still out there who say, if you've been revived 2 or 3 times, and in fact you come back again, where does government's role? Does it continue with that? Or should we mandate that you get into treatment if you're going to continue with this type of situation? I'm going to stop with that and go on from there. Thank you.
Before we turn to the representative, let me just mention one thing. I know that some of you are live tweeting this event. The hashtag that we're encouraging you to use is #AddictionIs. So #AddictionIs. With that, representative.
Thank you. Good morning. Good morning. Good morning. Now, before we talk about the critical issue that is, in case my mother is live tweeting or watching this, I think the record needs to be clear that I too am a Villanova law grad.
I'm sorry.
Only my mom would care. We could keep on going into the thing that's important, but she said, "Why didn't they mention that you went to Villanova Law School?" So I was on Professor Poole's track. On Professor Poole's track, so I had her.
And you've got an absent-minded professor in the room, so I was supposed to mention the hashtag too at the beginning. So it's a good thing I showed up.
It's good to be back at this beautiful new law school. Of course, I was across in the old days, but I'm glad to be here this morning, just to give you a little bit of what my perspective is and where I'm coming from. So I'm an 80s baby, and I'm from Southwest Philly. So that means a few things immediately, and especially for folks who are not from Philly and did not grow up either in the inner city or near the city in the 80s. So that means I was born in the middle of the crack epidemic. I am not a crack baby. My mother, my father, my parents never struggled with drug abuse ever. That was not an issue in our immediate household. However, there were many family members and people we knew in the community and people I knew at church and people I knew growing up whose parents were not present due to drug addiction, particularly during that time frame in Philadelphia. It was not uncommon to see crack vials on the street when you're walking to the school bus. It was not uncommon to hear so-and-so is strung out, and I'll use this air quotation mark. It wasn't uncommon at all because during that time frame in inner city Philadelphia. What we're seeing happening nationally with the opioid and heroin epidemic was happening in Philadelphia and other similarly situated cities across the country, albeit not exclusively with heroin. That being said, when I left this prestigious law school, the Harvard of the Main Line, I went to work at the Defender Association of Philadelphia. And I worked there for almost 10 years. And in my practice at the Defender, it was not uncommon for me to represent individuals who were strung out. And I'll go to those quotation marks again. Those individuals varied. It was not always a young person. It was not always an elderly person. But it was not always a man and it was not always a woman, and they did not always look like me. They were not always of color. They were not always from the inner city as well. I had a variety of clients in that practice, and standing up and representing the accused, the indigent, it was not uncommon for me to tell the court that I needed a little bit of leniency because Mr. So-and-so or Miss So-and-so sitting next to me was not only dealing with life, because we all can deal with life and struggle with it, but they were also dealing with serious addiction. And when you're also dealing with serious addiction and you find yourself as a victim of substance abuse disorder or substance use disorder, it makes life much more difficult to manage. And the decision-making process that a person who is not using any sort of controlled substances or prescribed substances, it's very different. It's worlds apart. And the decisions that are made often when one's under the influence and when one is addicted, it's too often that they end up with the secretary here on the end, Secretary Wetzel, in one of our institutions. Whether it's locally, where I used to have clients beg to stay on State Road, and that reference, for those of you who are not familiar, means to stay in the county prison so that they could do a methadone program, so that they could be weaned off of their heroin addiction or whatever else similar that they were using. Don't let me go upstate because I really need to be on a methadone program. And I'm not going to get that if I get sent to Graterford or if I get sent to Muncie or Cambridge Springs. Please keep me here locally, Miss McClinton. These are the cries for help that I received so often. It was just one that would make any practitioner distraught. Because we have this system, we've got drug treatment court in Philadelphia, and depending on your background and what types of prior record you have, you may be able to walk into the system addicted and scared and afraid and not sure what's going on with your children and dependency issues, but you might be able to walk out without a conviction if you qualify for drug treatment court, and if there are spaces open for drug treatment court, and if the judge and the district attorney who's assigned all agree that that is the best method for you. And in a system where you are worked very, very intensely and your workload is significant, and even in Philadelphia where we have very progressive social justice and criminal justice reform happening every day, everyone is not able to get the treatment that they need. So after spending several years in the court system in Philly, I ended up able to represent my neighbors where I grew up in Southwest Philly and West Philly, but I also go into the county, so I'm not only an urban legislator, I represent Delaware County, both Darby, Borough, and Yeadon. And in my time in the legislature in Pennsylvania, although brief, I've been able to see our legislative response to this national crisis. As we just heard from my testifier on the right, the reporting is not what it should be. So while the statistics indicate that in 2015, 3,300 people died from opioid overdose in Pennsylvania, it's very likely that there is a much larger number, but we just don't know about it. That means it could go from 3,300 individuals to perhaps 4,000 or 5,000. But whatever that alarmingly high rate is, It's unacceptable, and it is scary, and it's terrible to see that it's happening not only in our rural communities, but also in our urban communities and suburban communities as well. All throughout this Commonwealth, we are seeing a reflection of the national crisis that's happening, where people are addicted to these strong painkillers or addicted to heroin or whatever track it takes, whether it's one that leads to one equaling two or whichever direction. It is alarming. And as a result, we have seen a response from my colleagues in Harrisburg, and we've seen a response also from Governor Tom Wolf in his time in office. He was there 1 year before I came. And in the time that the governor's been here, Governor Wolf has started the prescription drug monitoring program, which there have been some references to that already, where the goal of that program is to help doctors and other healthcare professionals to make sure that everyone is getting and dispensing the medication safely, and that prescriptions or that pharmacists are making sure that they have a new checklist to kind of monitor this thing. In addition to that, there are the guidelines that were implemented for prescribing opioids. And also, we heard from our state physician talking about what the checklist includes and what types of things doctors need to consider when prescribing these types of drugs to patients. And then there's the drug take-back program, the prescription drug take-back program. But depending on where you live, once again, that could be a hindrance on whether or not you can safely dispose of these types of prescription. Additionally, the Centers for Excellence were created by the governor, and they're throughout the whole state. They're not just in one part of the state. There are 45 of them, and each of the Centers for Excellence have the current capacity to treat between 10 and 11,000 individuals who are addicted to drugs. And with those treatments, they're able to get comprehensive, holistic treatment, of course, with the ultimate goal that they will be able to break the cycle and not be addicted any further. One thing that I've personally been able to be a stakeholder with is the newly created, from our Pennsylvania House, the Hope Caucus. It's called the Hope Caucus, and I have some colleagues that created it, and I'm a member of the Hope Caucus. And what that stands for, that's the Pennsylvania Heroin, Opioid Prevention and Education Caucus. And the goal is simply what it says. My colleague from the West, from Allegheny County, Representative Ed Gainey, came to the floor of the House earlier this year and asked a question and said, stay in your seat unless you know someone who has been affected by drug addiction. There are 203 members in the chamber, and there was not one member in his or her seat when that question was asked. And as a result, both Representative Gainey and Representative Aaron Coffer worked together to create this dialogue on what we need to do legislatively to respond. Now, there are critics that say, well, the legislature should not respond. The legislature should be ahead of the game and on top of it. But we're in this crisis just like all the rest of our neighbors, just like my constituents, just like your neighbors wherever you live and wherever you're from. We're all facing this crisis at this time where the alarm is sounding, so we're all responding. Whether you are a medical professional, whether you're a lawyer, whether you're a doctor, whether you are a legislator, or whether you're running some type of center to address these issues. So with the creation of the Hope Caucus, one of the things that we did this summer was had a series of policy hearings to educate our colleagues on how important of an issue this is and how we can respond. We go back to session on Monday coming, the 19th of September, and on Tuesday the 20th, we're going to have a big rally in the Capitol under the main dome to talk about this issue. But not just to talk about it, but to keep the fire going with the political will, with all of the things that we mandate, legislate, that we oversee, that we keep functioning in terms of our government. This is also one of them that we have to pause and really take a moment and examine to make sure that our response thus far has been effective and what we can do in the future to ensure that we can curtail these deaths, curtail these overdoses, what we can do to address the folks who are battling this disease every day. Before we ended our last session in the summer, Governor Wolf stood with almost the entire House. We had a big press conference and said that he's going to be calling a special session together only to focus on these issues, to try to get legislation through our committees onto the floor of the House and voted and sent to the Senate and have them do the same. And you know, if you happen to follow even a little bit closely, how every year each of myself and my colleagues, we release thousands and thousands of bills, but because of the way the process works, many of them just kind of remain as bills. So we're doing something about this, and we're hearing how critical of an hour we're in, and we are responding to it accordingly. So there's several bills, and we're not going to detail all of them, but as we come to a conclusion in our opening remarks, there's several bills that we have that are responding. Some of them were referenced already. The ones that I have most concern about is the idea that we can't over-police and punish our way out of this problem. I'm probably very biased, full disclosure, because of my time as a public defender, but I've learned in that time, it didn't even take as many years as I was there, that we can't punish our way out of a problem. Our largest appropriation goes to corrections every year, and my constituents say, stop funding the prisons, fund the schools. And it's not that simple, because we have people there that we must provide a safe environment for while they're being rehabilitated, right? But we can't over-punish our way out of it. So some of the bills pending, I will be standing up, speaking on the floor, and reminding my colleagues that bringing back mandatory minimums will not stop these deaths, will not end addiction. But we are responding, and we're here, and I'm hoping that in the time that we're here, we're able to get even more, not political will, but legislative ideas. You see me taking down notes because I'm listening, and we'll take these ideas back to Harrisburg with me. So thank you.
Thank you very much, alum. Dr. Hyatt.
06.
So as a speaker, I have the unenviable position of following the representative and leading into the secretary. As a criminologist, unfortunately, I'm also placed in the position where I have to show you data, which I know is not everybody's or every lawyer's favorite thing to look at. So the bottom line of what I'm going to talk about for the next 15 minutes or so is already up on the screen. I teach undergrads, I know how this works. And so what I'm going to argue for is a narrowly prescribed policy response applicable in a wide range of situations, but particularly for individuals involved in the criminal justice system. So those folks already under the Secretary's supervision, but also in community corrections, both at the state and county level, as well as in the myriad of jails that we have here. So what we're talking about is medication-assisted treatment. And what this is, it includes a pharmacological treatment along with some sort of behavioral therapy to encourage individuals to overcome the challenges associated with addiction. One of the more promising options, and something, again, full disclosure, that we're exploring here in Pennsylvania is something called naltrexone. And there's one form of it that I'll talk about that can be injected into a participant, and then for the duration of its active period, about 28 days, they won't feel the effects of opioids. And that's particularly important during the particularly stressful time when individuals are leaving the custody of incarceration and returning back to their communities. So we've heard a bunch of different statistics over the last couple hours about how pervasive and problematic heroin and opioids are. That's particularly true in individuals who are involved in the criminal justice system. We know for a myriad of reasons that they are particularly vulnerable. We also know that over the last few decades, we've seen explosive growth in correctional populations. We here in Pennsylvania have enjoyed some reductions over the last few years, due in no small part to the efforts of the Secretary and other folks. But at the national level, we've seen some pretty sustained increases with small decreases due to large policy activities, particularly in California. But the takeaway from this is there are an enormous number of people who reside under the supervision of the state. At the same time, we've seen significant increases in rates of opioid abuse. Obviously, we're all here today because we recognize just how pervasive this particular problem is. So what we talk about and what we know is a fact is that there's a pretty close relationship, not just in the slope of those lines, but in these two particular problems. So this is kind of a difficult slide to read, but what you can see here is, according to this study done in 2009, 29% of local jail inmates, 32% of state inmates, and 26% of federal inmates acknowledged that they were under the influence of drugs at the time they committed their offenses. That number jumps up even higher when you look at the number of individuals who report abusing drugs in the month prior to their incarceration. It's almost half the individuals. What's particularly problematic in light of that is the number of individuals who receive treatment while they're incarcerated. So 7, 15, and 17% looking at local, state, and federal inmates. So that highlights the disparity between the size of the problem and the resources that are currently available in order to treat those individuals while they're in prison. So if you look kind of more broadly, other studies have shown that it's slightly higher, between 40 for state individuals and 49% of federal inmates, but most of those are limited to self-help or peer counseling groups, and they don't include the trained resources of medical or DNA professionals. So other studies have recognized that this is a much more pervasive problem even than we may realize. And as other folks have already said on the panel, up to 85% of all inmates may have a drug and alcohol problem either related to their incarceration or something that happens secondarily. So one of the more promising options, at least for this particular population, given the resource constraints that we currently operate under, is something called medication-assisted treatment. So we recognize that addiction is a function of a number of different factors, and it's been particularly difficult to tease out the unique factors that correlate with heroin abuse, but it's largely recognized to be both biological and psychological. So what medication-assisted treatment does is it offers an opportunity to address the biological components. So there are three common options that are used: methadone, norepinephrine, and naltrexone. And I'll go over them in a little bit of detail, but I'm not a medical doctor nor an expert on the pharmacology of it. But also recognize there are other options, including prescription heroin, which you can now get in Canada as of last week. Highly illegal here in the United States. I don't recommend anybody pursue that. So these are the table that just kind of outlines the three most common treatments. So methadone and norepinephrine operate by going into the individual system and binding to the receptors where heroin or opioids would go, and thereby simulating the effects of the drug without giving them the full euphoric effect. Naltrexone operates differently. It's what we call an antagonist, and it actually blocks those chemicals from binding to the individual's brains. So generally we find that when methadone and norepinephrine are made available, we see a significant decrease in fatalities. It's also been shown to have other benefits, including retention in treatment and reducing the risk of disease transmission, things like HIV and hepatitis, that also correlate strongly with injectable drug use. However, they're not as common as they could be. So some studies estimate that it's only 1/3 of all patients who are in treatment centers would be able to receive them. What we do know is when people get these particular kinds of treatments, there's a fairly long history of some successes. So this is from a study in 1991 that shows the effect of methadone maintenance, so taking this over time. And what you see is a pretty significant reduction in drug use. Obviously, 100% of people are using drugs when they're using drugs. And after 4 years, the individuals who continue with methadone maintenance, only 29% of them acknowledge using heroin. Those benefits are even more noticeable when you combine the medication-assisted therapies with biological or other kinds of peer group counseling. So that's the difference between the blue line and the red line there. Norepinephrine, which functions similarly but not exactly in the same way. This is from a more recent study where you find that individuals who are provided norepinephrine, it increases their retention of treatment, so they stay in treatment longer. That obviously associates with higher levels of success. The side effects are there. They are relatively mild in norepinephrine compared to methadone, and naltrexone is more mild, but that is one of the biggest issues. So there's other experimental research that's out there, and I'm happy to share any of these studies with anybody who's interested in statistics after the fact. But it shows that buprenorphine and methadone, the two more common options, are fairly similar in how effective they are. And they, in this particular study, correlate with reductions in how severe individuals say their particular addiction is. The newest player on this scene is naltrexone. The injectable version that I talked about earlier is called Vivitrol. And what this does is, instead of requiring a daily pill, it's a once-a-month injection. It prevents individuals from experiencing that euphoric effect of heroin, and it assists them with returning to the community, which is especially important for individuals coming out of custody. It's generally the case that individuals in prisons and jails are detoxed. They detox as part of their medical clearance going into the prison, and especially for the individuals in the state system, they're there for at least 2 years in most cases, and so they have not had the opportunity to partake of many drugs during that time period. So it's an ideal time for them to begin some of these therapies, especially naltrexone, because it blocks the effects of the drug for when they return to the community. So generally, naltrexone was actually developed for the treatment of alcohol abuse. It's more recently expanded into the opioid abuse realm, and the side effects are generally mild. And the research that's out there, and there's not as much as I think we would like to see, and that's especially true for the justice-involved populations, suggests that it's effective. So I won't really explain the nuances of this particularly ugly graph, but each of those lines represents one study about the effects of naltrexone. The bars tell you how certain they are, how much error there is. It's a confidence interval. And basically what this study does is it combines all of those little squares into those diamonds. And what you can see is the diamond on my right favors naltrexone, which shows that overall the evidence suggests that it's effective in reducing relapse to drug abuse. It also can prevent this. That is, in fact, in monkey using drugs. Buprenorphine and naltrexone have been shown to reduce self-administration of cocaine by rhesus monkeys. I don't know what to make of this. There are several limiting factors, especially though when we're talking about justice-involved populations. So the first is the side effects. Especially for methadone, they can be fairly significant, and that correlates with individuals dropping out of treatment. So weight gain, decreased libido, cognitive changes, and things like that discourage individuals from continuing to take their daily medication. That obviously correlates with poorly adherence to the required schedules, which makes the treatments not as effective. Particularly important for our justice-involved population is the street value and potential abuse of buprenorphine and methadone, and also the generalizability of the research that I've shown you guys so far. So on that first issue, this is a study from 2012, and what you can see is a pretty significant increase in the line of circles and the line of triangles. And this is the rate of medically assisted treatment drugs that are being sold on the streets because they have abuse potential. So you can take enough methadone to have a biological effect, and so individuals are doing that. And that's where you see here on this figure where it shows that there's been an increase in reported cases of abuse of medication-assisted treatment. So obviously that's problematic in the general community, but for individuals who are under the custody of Department of Corrections, giving them a drug that can be abused on a daily basis is particularly challenging and problematic from a policy perspective. The second issue is the generalizability of the research that exists. So we know that individuals who are involved in the justice system, especially those who are incarcerated in state correctional institutions, they're different in a lot of ways than everybody else on the street. So we've heard a lot about this particular opioid and heroin epidemic because it struck populations not traditionally associated with drug abuse problems. The individuals, to build off of what the representative said, the individuals who were the target of the crack epidemic are not necessarily the same individuals who are driving the growth of the heroin problem. So we do have a little bit of research. So this is a study on crime and methadone maintenance. And what you can see is over time, individuals who remain in treatment commit fewer crimes. So there's been a significant reduction in the number of crime days that people in treatment engage in relative to those who drop out. The same thing is true for studies where methadone is offered inside of prisons. So in this particular study, they offered methadone and compared that to counseling. And what they found was there was a 65% relapse rate for individuals receiving only behavioral counseling, and a 25% relapse for those individuals getting MAT, in this case methadone, as well as behavioral counseling. So the problem is that the opportunities to receive methadone within the correctional system are fairly limited. In some studies, it's been found that only 12% of all correctional facilities offer methadone maintenance in any form. It's barred in the vast majority of them, including here in Pennsylvania, for some of the reasons that I've outlined already. The research that we have is also limited in terms of its application. We care for a lot of reasons about the relationship between relapse and recidivism, especially from a policy perspective within the criminal justice side of this particular problem. And the data that we have just aren't that good. We rely on self-report data when individuals say they committed a crime, or if they say they were arrested or something like that, relative to looking at administrative records, the police, and things like that. So there are a few studies that have been done looking at naltrexone with the parole population. There's an older formulation that's a pill. And what we see here is that individuals who are receiving naltrexone treatment, while they're under community supervision, are revoked. They have their parole or probation taken away, and they're sent back to prison at significantly lower rates, 26% relative to 56%. So, when you think about the cost of supervising someone in the community, that's a fairly significant savings. It also, obviously, there's a human cost associated with keeping people out of prison. There's much less research about injectable naltrexone, and that's particularly challenging since we see this in some circumstances as particularly promising. So one of the few studies that are out there found that among individuals involved in the justice system, injectable naltrexone had a significantly longer time to relapse. It was a solidly designed experiment. The problem was that they weren't working with a well-prescribed sample. So basically they went and they used a convenience sample. So they found individuals who were in treatment, who had recently been in prison, and asked them to participate. Looking at this particular MAT family as an option for reentry, as a policy prescription at the governmental level, we really need to understand what it would mean to integrate that directly into the reentry process. And the biggest hurdle into doing that is attitudes. So the pervasive attitudes about MAT is generally that you're trading one addiction for another. So this makes it particularly problematic for individuals who are trying to get a program off the ground, especially for the vulnerable populations involved in the criminal justice system. And so what we did in Pennsylvania was we went and we asked individuals under the custody of the Department of Corrections what their attitudes were about naltrexone, the injectable formulation, relative to methadone, which even though it's not offered in the DOC, it's much more commonly known. And what we found is that people were fairly unaware of the benefits of MAT treatment generally. You can see on the top that individuals did think that taking naltrexone was replacing one addiction with another. And in some cases, there was a small but not insignificant percentage of individuals who thought that taking heroin was better than getting MAT drug treatment. So that's a particularly challenging mentality when you're trying to institute this at the policy level. So overall, this just compares the attitudes to methadone to naltrexone, and you can see that the negative attitude is higher for naltrexone. So where does this leave us here in Pennsylvania? One of the things that I'm working on with the Secretary's agency is finding out more specifically what it would mean to offer injectable naltrexone MAT to individuals returning to the community. So as a segue into the Secretary, we've started a pilot study to look at exactly what would happen, what are the benefits and what are the costs to offering injectable naltrexone to individuals inside of the SCIs that bridges their time into the community to offer them the ability to avoid some of the stresses and pitfalls associated with returning to the situations that got them in trouble in the first place. And with that, I think I will turn it over to the Secretary.
Secretary, please.
All right. Well, first of all, thank you, and I'd like to thank my fellow presenters. Really good, rich information. I have a slightly different perspective in that in Pennsylvania, the Department of Corrections is comprised of 27 state prisons, 50,000 inmates, slightly under 50,000 inmates, and 15,000 staff. And that doesn't count our 50 plus or minus 5 halfway houses all over the Commonwealth. And so when you talk about the opioid epidemic, I wouldn't say we're the front lines. I think the county jail system in Pennsylvania, which for some reason in Pennsylvania we call county prisons, which is a weird term, but corrections started in Pennsylvania, so we can say whatever we want, frankly. That's really the front lines. And in Pennsylvania we have 61 county jails. And we heard earlier, especially some of the rural county jails and some of the challenges of the significant increase of individuals addicted to opioids coming into their system. The criminal justice system works as a filter or a funnel, as Al Bloomstein said. So more people get arrested than get incarcerated at the local level, less end up at the state. But even with that understanding, over the past 6 years, we've seen a doubling of the number of individuals coming in addicted to opioids in our system, from 6% of every commitment to now 12%. And we're talking 12% of 20,000 people who come in every year. Now, I can't do the math on that, maybe he can, but it sounds like a lot of people to me. And in particular, the significant growth in that population. And I think one of the challenges from a policy standpoint that we're facing is the fact that our systems don't change easily and sometimes don't change ever. And frankly, we're not going to get it done doing business as usual. And there's an African proverb that says that when the music changes, so does the dance. And we haven't changed our dance much at all. And so I'm going to start by trying to be a little aspirational and just ask you to suspend belief for a little bit, because I want to talk about what a criminal justice system would look like that made sense. I know it's difficult. We don't really have a point of reference for that, so I acknowledge that. But I got to tell you, if we were sitting here today to design a response to the addiction issues, specifically the opioid issues, but addiction in general, at the state level, we're talking over 70% of our population suffering from a substance use issue. Right? And listen, for all these years, we've done business as usual. And if you look nationally at 5-year recidivism rate, you're looking at about 3/4, between 2/3 and 3/4 coming back. So clearly it is not working. So if we would try to design a system that's responsive to the people who use the system, which in theory is what we should be doing in government, right? You would think that we would build a system that responds to the needs of both the individuals who come through the system and the individuals they impacted by committing crime. I mean, I don't think that's a high bar. Unfortunately, it is. And I would suggest to you that the first step in this make-believe system would be to understand what the root cause of the crime is. See, our approach to drug policy over the past 4 decades has basically been lock people up, and when the drug problem gets greater, lock more people up for longer. And the unintended or intended consequence, I'm not a big conspiracy theory. I don't know anybody in government who keep a secret, for the record. But it's true. But the result of that has been a significant increase in prison and jail population throughout the country. And what doesn't get talked about enough is the significant increase in cost. And the reality is, there's only so much money that's coming in to state government. And actually we're third, by the way, not the first.
Thank you for correcting the record.
Yeah, I mean, so where we're at from a budget standpoint is Department of Ed and Department of Human Services are both between 11 and 12 billion. We're third at about 2.4 billion. But the reality is, as corrections eats up a bigger piece of that pie, there's less money to go to the other areas. And the real ironic part about that is what we know is that funding and developing more services in those areas would lead to a reduction in the prison population. But again, because drugs are illegal, we have one lens, and that's the lens of arrest people and put them in a system that historically has been ill-prepared to respond to addiction. So what happens today in the vast majority of county jails when somebody gets arrested and comes in, especially with an opioid addiction, is that they detox with very little medical treatment, very few places, DOC included today, shouldn't be for long, but today, don't detox using medication. So basically our motto is suffer. And in some cases, suffer and then die because you're an addict. And I don't know how that's okay. I don't know how we're okay with that, but we are. And so I think it's important that we start from a real place. And so the unintended or intended consequences of using the criminal justice system as the nexus and the delivery system for drug treatment is a failure. And even when drug treatment is effective, it's an inefficient, meaning expensive, way to deliver treatment. And one of the things that gets lost in this discussion is the fact that if you're low risk, and it's possible to be low risk and have high needs, and you come to a state prison, you're going to come out more likely to commit a crime. And that's just the reality. But when you hear things like mandatory minimums that take discretion away and frustrate the system from making good individual decisions, we just get further down the road to continuing to continue this path of insanity as it relates to addressing addiction. So if we were designing a system that was truly responsive to this issue, the first step is identifying root cause. And if an individual has an addiction, you have to treat that addiction. And you can put them in state prison for 10 years. If we don't address the addiction, you know what you're gonna get? An addict who's 10 years older and not less likely to commit a crime. And at the state level, you're gonna invest about $90,000 a year to do that. That's the reality of where we're at. Doesn't make sense at all. So the first step, identifying the root cause. And very few places in Pennsylvania and in the country actually look at risk and needs when an individual is first arrested. Now, you may think that doesn't sound unusual, but I would tell you it does. Because if you went to a doctor and you told them what was wrong with you, and the only thing they did was take a guess based on what you told them as to your treatment trajectory, you'd get a new damn doctor, right? Because that doesn't make any sense. You want tests, you want the doctor to understand exactly what is driving your illness. Why wouldn't we expect the same out of the criminal justice system? And then the second step is identify how we can put the individual on a path to not commit another crime. And the presumption should not be that we're going to incarcerate them first and then try to figure it out. But that's our approach. Our approach is the default is incarcerate. And at the county level, it's very difficult to build a treatment infrastructure inside your county jail. And I would argue that it probably doesn't make sense. Because what you have, when you build a really good treatment program in a jail, you know what happens? We sentence more people to it because they can't get treatment in the community. So yes, we're delivering treatment, but we're also potentially increasing their risk to commit another crime. But that's where we're at. And so the second step is figuring out how to put the individual on a path to not commit another crime. And with addiction, you have to address that addiction. Now, one of the things that happened early last year when Governor Wolf came on is we became an expansion state, which frankly gives us the opportunity to divert somebody pre-trial, or the new term is deflect, whatever. I just think we should do this groundbreaking thing, like put someone where they're gonna get better, right? Wherever that is. But it gives us the opportunity to divert somebody out of the criminal justice system and into treatment, funded at least in part by federal dollars. And so what that requires is systems to become agile enough, and agility is never associated with corrections, ever. But be agile enough to sign individuals up and plug them into the treatment infrastructure. Now, as was alluded to earlier, we are in catch-up mode on building a real treatment infrastructure. And oftentimes in government, we get really focused on why we can't do things. And if we're going to take that approach, then we're going to be doubling the number of people who OD over the next 10 years. If government doesn't have the courage to stop looking at why you can't and figure out why you can, this is not going to go away. And so I think as you see the infrastructure, you talked about the centers of excellence, which is basically like one-stop shopping. So have all your behavioral health needs met in one location, which is really a smart approach. And in the Department of Corrections, we're going to be replicating that approach instead of doing our traditional drug and alcohol and community corrections, we're going to replicate the approach. And I think it's important, and one of the things that's so exciting about, you see all these bipartisan efforts going on, is because to respond to this, it's going to require a convergence of efforts. So government generally functions around funding streams, as opposed to functioning around the individual and meeting the needs of the individual. And again, if we keep focusing on stovepipes and funding streams, it's not going to address the varied needs of the individual, to include the criminal thinking. So there's a criminal cognitive behavioral approach that's required, but also the addiction. And then the other thing that's often overlaid, and in our case, 28% of our population are on our mental health roster. So when all these things come together, and then we put people in a jail or a prison, even worse, the outcomes are going to be abysmal. So if we can deflect people out of the system early on, plug them into hopefully a growing behavioral health infrastructure, and if counties do this, and we have at least one county piloting this, where they divert individuals, put them in treatment, and then when they come in front of a judge, there's one of two outcomes. Number one, they've done everything they've been asked to do, and they're sticking to their treatment. And then that informs the judge as far as the sentencing decision, right? So traditionally, if someone just sits in jail pre-sentence, and if you're poor and of color, you're likely going to do that, quite frankly, we don't get any value for that. You don't get a return on your investment when someone is sitting pre-trial. And then what complicates that even more is that our pre-trial case processing is not quick. So you could have an individual who comes in for a retail theft or several retail thefts, and the sentence could call for a 3-month sentence, and because of our inefficiencies, they'll sit 6 months, 7 months, 8 months. And the chance of getting treatment in that time frame is highly unlikely. Some counties it's possible, but highly unlikely. So in essence, as taxpayers, we're just wasting every dollar spent when we could divert it. Now, there's another path too. You divert someone, you put them, and they don't follow treatment. So what do we do with them? We do what we do now, just lock them up. But to not try to get people out of the system in the first place doesn't make much sense at all. And then I'll talk briefly about the services delivered in state prisons. We are very fortunate in Pennsylvania in that we have, every one of our prisons has an inpatient drug and alcohol program. We are outliers certainly in the country. And when someone comes in our system, we actually assess for addiction. Again, we're outliers in the country as it relates to that. And then we put people in the appropriate level of, in general, the appropriate level of treatment. Inpatient, we call them therapeutic communities, or outpatient. And then we also have a treatment infrastructure in community corrections. I think one of the really potential good practices that will perhaps improve our outcomes is this medication-assisted treatment. And we started with Vivitrol. And if you're interested in medication-assisted treatment and what we're doing, it's on our web page. It's www.cor.pa.gov. We have a whole page dedicated to medication-assisted treatment. And when we first rolled this out, we were very naive in thinking that we could just kind of put it out and staff would embrace it and the public would embrace it. And so I can tell you the start was abysmal. Now we're about slightly below average, so we're making great progress over the past 2 years. But one of the things we found out through polling is that we had to do a lot of education. We had to educate staff members at the value, because as you alluded to, that we're going to substitute one drug for another. I mean, we wouldn't say that for diabetes or anything else, which is pretty preposterous. And the fact that this is an evidence-based practice means it works. So the notion that we wouldn't do any of this stuff because we're substituting one drug for another is just, we got to get over that if we want to get over this epidemic. But we also had to educate to family members and to the inmates themselves. So we have a pilot that started with females at Muncie only. And that was in either 13 or 14. And frankly, we started with females because that was a group that we thought we'd get less resistance to start with because of the cultural impediments. And frankly, I think we're the first entity in the state to do medication-assisted treatment. So it was really getting out on thin ice. And it was certainly for another administration that was let's just say a little right of where we are now. A little right, not much. So we started with that, and we did a process pilot to understand what were the impediments. Now we've expanded to males and females, and I believe 6 prisons, but it could be more than that. You're doing the research on that, right? Is it 6?
5 now and then more coming up soon.
See, what my researcher knows, he just lies and says whatever I say. We haven't worked that out yet. So we've expanded it, and one of the things that we committed to do is do a random controlled trial. So randomly assign people to either the treatment group or the non-treatment group, which I got to tell you caused a big stir culturally in our department. We had staff members who felt like we were being unethical, but I feel strongly that if we ever want to have a sane, imaginary criminal justice system, we really have to measure outcomes. And when something works, we should do it, and if something doesn't work, we shouldn't do it. I know it's groundbreaking, but it really is in criminal justice, because we don't expect outcomes from our criminal justice system. And because of that, we've gotten away with bad practice forever. So again, I think I'm optimistic, but by the same token, I think it's important for you as taxpayers, as constituents, to require our system, to require government, to really be responsive and to stop looking at barriers and to stop looking at problems by department and look at problems by individuals. And this notion that people would use this crisis as a Trojan horse to lock people up for longer, it's just crazy, and it just can't happen. Because as the DOC grows, money for treatment and money for everything else goes down. So thank you very much for your time and attention.
So I'm going to open the floor and also in the overflow room for questions, but let me just take a moment to emphasize one thing that the Secretary said, which is that the use of a random controlled trial in this context really is remarkable and, speaking only for myself, I think extraordinarily commendable. Mr. Denk.
We had probably 10 to 12 district attorneys from around the state testify at our hearings, and they would echo completely what the Secretary has said about those who enter the criminal justice system because they've committed a crime due to a substance abuse problem. That being said, they also talked about those who commit crimes because they're dealing drugs and they're dealing them as a business, and that we do need to treat them differently and become much more strict about how we deal with them in the criminal justice system. One DA said that if you're dealing drugs and you get busted and you have a minimal criminal history, if none, the likelihood is that you'll get 3 to 12 months in the county jail. Not enough of a deterrent to get them to stop dealing drugs, or someone else will come in and replace them because there's insufficient deterrent from how they're treated. So we should not forget those folks as we look at others who are really in need of our assistance.
And I would respond to them respectfully. There's no research that shows deterrence works. So I mean, I hate to throw facts in the mix. But we use that stuff all the time. We say, oh, they have to serve longer. We certainly need to lock up drug dealers who are in it for business, right? But we have the vehicles to do that. I mean, we have 5% of the world's population and 25% of the incarcerated population. I think we figured out how to lock people up. I don't think we need a new solution for that. I think we need to be smarter. We need to use it more with precision. So, and I think oftentimes, and part of this discussion around the special session is part of it is gonna be around mandatory minimums. And we conflate mandatory minimums with locking people up. Like if we don't have mandatory minimums, drug dealers can't get a long time. That's inaccurate. That's completely inaccurate. So I think it's really important that if we could legislatively come up with a mechanism to accurately identify that, but our history has not been that. And legislators and Senator Greenleaf would tell you, who passed a lot of the mandatories, that when you go through the process of legislation, it gets less precise, and we end up locking up more than the people we're targeting, and that's the risk. And again, our cost continues to grow by $150 million a year for the same number of inmates, just infrastructure costs. $150 million a year. That's a lot of treatment centers. That's a lot of money in education, keeping kids in school. So I think this is a critical discussion around balancing treatment with enforcement, and I hope that that's not something we rush through in the next 6 days or 6 sessions or whatever's left this fall.
Well, we'll try not to, Secretary. We won't rush it. But in regards to the punishment and deterrence aspect, punishment is necessary. It is key, because if punishment does not occur, then we'll see an even worse cycle of crimes being committed. And in certain drug trade industries, particularly in the city, there's violence that's often associated as well. My main concern, though, is that even when someone is given a prison sentence, whether it's lengthy or brief, because the demand is so high, they've been replaced the night they were locked up. I mean, let's not think that people at that corner, if it's in a city or at this house where they're manufacturing drugs in the rural community, that no one is out there supplying drugs. Someone is still there. It's just not the person who's been incarcerated and accused at that moment. And that's what's unfortunate when you're addressing this type of crisis. The demand is skyrocketed because of people who are addicted. So if people are addicted, they are using drugs, and they're going to find someone to supply it to them. So whether we give someone, or whether a judge gives someone 3 months or 3 years or 30 years, I mean, I just would like to emphasize the fact that judges need discretion. And when mandatory minimums are implemented, discretion, judicial discretion is not allowed anymore. It's as if that not sentence the individual who's in front of him or her. And that is what I am not a fan of, and I don't think will help clean up any part of this system.
Yes, ma'am.
I'd like to make a few comments listening to this. First of all, I do a lot of volunteer work in the city, and I'm mentoring a number of inner city youth, and I've had contact with the city school system. My husband has been doing community psychiatry for years and worked as a psychiatrist in the prison system. He's been in 14 different prisons. One of the things I heard from him was the problem of maybe somebody who was locked up for possession. He was clearly seeing people who had, had done heinous crimes who didn't belong in prison. But he was seeing many people he felt really should have been out in the community being treated, and we're spending a fortune keeping them in prison when they could be in a different situation. But we're also, I've heard comments of root cause and just sort of some side comments about money for the schools. And that is one of the root causes of the drug problem. In Philadelphia, we have close to 50% of the high school students are dropping out. They don't have an education. And this is, we had a program here at Villanova some time ago on the education. But the number of youth dropping out of the city school system and on the streets with not too much promise of being able to do anything else is another one of the causes of people becoming addicted. So we really do need to look at the social services and the education as part of the drug problem.
Well, I think that's certainly consistent with what you heard up here, that looking at these issues and problems in isolation has not been successful. Sir, did you also have a question?
I'm John Capuzzi. I'm a judge in the Court of Common Pleas in Delaware County in the Criminal Division. So to follow up with the Secretary, we have just gotten a grant for $237,000 because we recognize that there's a gap between the arrest and the preliminary arraignment and when they first appear in the Court of Common Pleas. We are now going to address it right at the preliminary arraignment by having a coordinator that will be able to assess the individuals and will divert them as bail condition to treatment facilities. If they violate the bail conditions, we'll no longer be dealing with the magisterial district judge. They will be dealing with me in the Court of Common Pleas. And it's in conjunction with the public defender and in conjunction with the district attorney, because we understand that when you put them right back on the street, there's this gap and they're right back in the cycle. So we're trying to find some evidence-based treatment, and the population we've identified right off the bat are 18 to 25-year-olds. based on the statistics we have, that would be most amenable to the treatment at that early stage. We hope to expand the program, but it is coming, but it's an upfront attempt to divert them from the jail system.
Thank you very much. All right, I think we have time for one more question. Yes, sir.
First of all, good morning, and thank you all for your participation today, so we appreciate it. My name is Sean Lavelle, I'm with Caring Treatment Centers, and one of the questions I had just to get your thoughts on kind of the state and regional level is that I think so much of the conversation we tend to have around this subject is as it relates to youth, basically that 18 to 25-year-old cohort. That's what we're seeing in the news, when so-and-so has passed away in their 20s or early 30s and they're young. A lot of what we're starting to see is this influx of seniors. So I'm curious at the state and regional level what we're seeing, what kind of conversations are happening around policy or programming as it would benefit the senior population, folks who have had hip replacements, who are now on various prescription medications and are now mixing that with their afternoon cocktail. That kind of a situation where a loved one has passed away and they're prescribed sleeping medication to get them through that disappear, that combined with other medications that they're on. So I'm very curious kind of what your take is on that and what we can be doing to address it.
You know, it's very interesting. Last year, so our population historically has a bimodal distribution. So we have a lot of young kids, a lot of older, but part of that is because we're life means life. So 10% of our population will never get out, 5,000 people. So that skews our age. But last year we saw a significant increase. Fastest growing group were older. And it was the first year we don't have any explanations for it, but it's consistent with what you're saying. And perhaps we can connect, and I connect you with my research department, because if we see it 2 years in a row, the opioid epidemic may explain part of that, but we've seen for the first time older new commits increase.
I don't have specifics, but I know the Department of Aging is looking at that specifically with the Department of Health and with the Department of Drug and Alcohol Programs. And just a real quick aside, I just got an email the other day asking if we might be willing to meet with some Amish sect leaders or elders, because there's a growing incidence of substance abuse within that population. And so it is, as we've heard, affecting all ages, all walks of life. And these subsets, if you will, are becoming identified and maybe needing special look as to what can be done.
So let me just read, there are a few questions we received from the overflow room. I'm not going to read all of it in the interest of time. One has to do with Dr. Hyatt's slides that perhaps he'd be gracious enough to allow us to post. And then the other was whether Vivitrol is being made available at the present time to prisoners completing sentences in county jails.
So actually, the Department of Corrections, working with Senator Scarnati, have a $1.5 million grants that we just got applications back for. 11 counties applied to replicate our Vivitrol pilot. So the hope is that we'll be able to get that money out to as many counties as possible and to leverage that spending to build an infrastructure to leverage federal dollars to maximize the use of that. So we have a handful of counties doing it now. We're hoping this 1.5 million really significantly expands it.
All right. So with that, and before we thank our panelists, let me just give you a little in the way of stage directions. There's time now, a brief time for lunch. There's a cafeteria available downstairs. We start up with the excerpted screening of Generation Addicted at 12:15. We encourage you, bring your food back, and we will see you then. Again, please join me in thanking our panelists.